Chapter 5: The Ovary and its Disorders. Anatomy and function of the ovaries. The normal ovaries occupy the ovarian fossa on the lateral pelvic wall overlying the ureter, but are attached to the broad ligament by the mesovarium, to the pelvic side wall by the infundibulopelvic ligament, and to the uterus by the ovarian ligament. Blood supply is from the ovarian artery, but there is an anastomosis with branches of the uterine artery in the broad ligament. The ovaries have an outer cortex covered by germinal epithelium. The most common carcinoma derives from this area. The inner medulla contains connective tissue and blood vessels. The cortex contains the follicles and theca cells. Estrogen is secreted by granulosa cells in the growing follicles and also by theca cells. The rare tumors of these cells secrete estrogens. A few follicles start to enlarge every month under the influence of pituitary follicle stimulating hormone (FSH), but only one will reach about 20 mm in size and rupture in response to the mid-cycle surge of pituitary luteinizing hormone (LH) to release its oocyte. After ovulation, the collapsed follicle becomes a corpus luteum, which continues to produce estrogen and progesterone to support the endometrium whilst awaiting fertilization and implantation. If none occurs, then the corpus luteum involutes, hormone levels decline, and menstruation begins. If fertilization and implantation occur, then human chorionic gonadotrophin (HCG) produced from trophoblasts maintains corpus luteum function and hormone production until 7 to 9 weeks gestation, when the fetal placenta unit takes over. Follicular and lutein cysts result from persistence of these structures in non-pregnant women. Ovarian symptoms. Ovarian masses are often silent and detected either when they are very large and cause abdominal distension or on ultrasound scan. Acute presentation is associated with accidents. Ovarian cyst accidents. Rupture of the contents of an ovarian cyst into peritoneal cavity causes intense pain, particularly with an endometrioma or dermoid cyst. Hemorrhage into a cyst or the peritoneal cavity often causes pain. Peritoneal cavity hemorrhage is occasionally so severe as to cause hypovolemic shock. Torsion of the pedicle, bulky due to the cyst, causes infarction of the ovary plus minus of the tube and severe pain. Urgent surgery and detorsion are required if the ovary is to be saved. Disorders of the ovarian function. Polycystic ovary syndrome (PCOS) is a common disorder that causes oligomenorrhea, hirsutism, and subfertility. The cysts are actually small, multiple, poorly developed follicles. Premature menopause is when the last period is reached before the age of 40 years. Problems of gonadal development include the gonadal dysgenesis, the most common of which is Turner syndrome. Classification of ovarian tumors. Primary neoplasms. These can be benign or malignant. They are classified together because a benign cyst may undergo malignant change. They fall into three main groups. Epithelial tumors. These are most common in the postmenopausal woman and are derived from the epithelium covering the ovary, or particularly for high-grade serous adenocarcinomas, the fallopian tube. Uniquely, histology may demonstrate borderline malignancy when malignant histological features are present but invasion is not. Such tumors may become frankly malignant. Surgery is advised, but their optimal management is disputed. In younger women with a borderline cyst, close observation may be offered following removal only of the cyst or affected ovary to retain fertility. Recurrence as a borderline or invasive tumor can occur up to 20 years later. Serous cystadenoma or adenocarcinoma. The malignant variety is the most common malignant ovarian neoplasm and is classed as high grade. 70% of ovarian malignancies, or low grade, less than 5% of malignancies. Benign and borderline forms also exist. Endometrioid carcinoma. This malignant variant accounts for 10% of ovarian malignancies. It is similar it is similar histologically to endometrial carcinoma, with which it is associated in 20% of cases. Clear cell carcinoma is a malignant variant that accounts for 10% of ovarian malignancies and has a particularly poor prognosis. Mucinous cistadenoma or adenocarcinoma can become very large. Mucinous adenocarcinoma accounts for 3% of ovarian malignancies. A rare borderline variant is pseudomyxoma peritonei, in which the abdominal cavity fills the gelatinous mucin secretions. An appendiceal primary tumor is more commonly the cause. Brenner tumors are rare and usually small and benign. Germ cell tumors. These originate from undifferentiated primordial germ cells of the gonad and account for 3% of ovarian malignancies. Teratoma or dermoid cyst is a common benign tumor, usually arising in young premenopausal women. It may contain fully differentiated tissue of all cell lines, commonly hair and teeth. It is commonly bilateral, seldom large, and often asymptomatic. However, rupture is very painful. A malignant form, the solid teratoma, also occurs in this age group, but is very rare. Yolk sac tumors are highly malignant and present in children or young women. This germinoma is the female equivalent of the seminoma. Although rare, it is the most common ovarian malignancy in younger women. It is sensitive to radiotherapy. Sex cord tumors. These originate from the stroma of the gonad and account for less than 2% of ovarian malignancies. Granulosa cell tumors are usually malignant but slow growing. They are rare and are usually found in postmenopausal women. They secrete high levels of estrogens and inhibin. Stimulation of the endometrium can cause bleeding, endometrial hyperplasia, endometrial malignancy, and rarely in young girls, precocious puberty. Serum inhibin levels are used as tumor markers to monitor for recurrence. Thecomas are very rare, usually benign, and can secrete estrogens and/or androgens. Fibromas are rare and benign. They can cause mixed syndrome, whereby ascites and a usually right upper pleural effusion are found in conjunction with the small ovarian mass. The effusion is benign and cured by removal of the mass. Common ovarian masses. In the premenopausal woman, follicular or lutein cyst, dermoid cyst, endometriomas, benign epithelial tumor. In postmenopausal woman, benign epithelial tumor and malignancy. Secondary malignancies. The ovary is a common site for metastasis, particularly from the breast and gastrointestinal tract. Secondaries account for 10% of malignant ovarian masses. A few contain signet ring cells, and if from the gut are called Krukenberg tumors. The primary malignancy may be difficult to detect, and the prognosis is very poor. Tumor-like conditions. The word cyst can include anything from the malignant to the physiological, but is often interpreted as cancer by patients. Endometriotic cyst. Endometriosis commonly causes altered blood to accumulate in chocolate cysts in the ovary. Such cysts are called endometriomas. Rupture is very painful, though uncommon. Functional cysts. Follicular cysts and lutein cysts are persistently enlarged follicles. Functional cysts. Follicular cysts and lutein cysts are persistently enlarged follicles and corpora lutea, respectively. They are therefore only found in premenopausal women. The combined pill protects against functional cysts by inhibiting ovulation. Lutein cysts tend to cause more symptoms. If symptoms are absent, treatment is not required, and the cyst is observed using serial ultrasound scans. However, because of the remote possibility of malignancy, if an apparently functional cyst more than 5 centimeters persists beyond 2 months, the serum cancer antigen CA125 level is measured and laparoscopy considered to remove or drain the cyst. Ovarian cancer. The silent nature of this malignancy causes it to present late, meaning that the disease is widely metastatic within the abdomen. The 10-year survival rate is therefore 40 to 50%. Epidemiology. There are 7,000 new cases per year in the UK, causing 4,200 deaths. The lifetime risk of developing ovarian cancer in the UK is 1 in 60. Rates increase with age, and the median age of diagnosis in the general population is 63 years. There is marked geographical variation. After decades of increasing incidence, a steady slow fall has been noted in the UK and many other European countries since the early 2000s. This may be due to widespread use of oral contraceptive pills (OCPs), which reduces risk. Histological types of primary ovarian malignancy: serous adenocarcinomas, high and low grades, 75%; endometrioid carcinoma, 10%; clear cell carcinoma, 10%; mucinous adenocarcinoma, 3%; other non-epithelial, germ cell, and sex cord tumors, less than 5%. Pathology. See classification of ovarian tumors. 95% overall are epithelial carcinomas, and the management outlined applies largely to this group. The grade of malignancy includes borderline, low, and high grade. Germ cell tumors are the most common in the rare event of a woman under the age of 30 years being affected. Primary peritoneal cancer and fallopian tube cancer are rare malignancies but share many similarities with ovarian cancer. These three cancers are managed in a similar manner. Etiology. Benign cysts can undergo malignant change, but the pre-malignant phase is not normally recognized. The risk factors relate to the number of ovulation. Therefore, in an early menarche, late menopause, and nulliparity are risk factors, whilst pregnancy, lactation, and use of the pill are protective. Ovarian carcinoma may also be familial, 5%, via the BRCA1, BRCA2, or HNPCC gene mutations. If two relatives are affected, the lifetime risk is 30%. If the BRCA1 mutation is present, the risk approaches 50%. BRCA1 and BRCA2 gene mutations with an overall prevalence of around 1 in 600 are also associated with breast cancer, whilst HNPCC, also called Lynch syndrome, is also associated with an increased risk of bowel, 80% lifetime risk, and endometrial cancer. There is increasing recognition that majority of high-grade serous adenocarcinomas, the most common type of ovarian cancer, actually originate in the fallopian tube. Screening for ovarian cancer. There is currently no UK national screening program for ovarian cancer. Unlike cervical cancer, screening is generally for early malignant rather than pre-malignant disease. Ovarian carcinoma presents late, and whilst the prognosis is much better for early disease, the recent result of a large trial, UK-CTOCS, involving over 200,000 postmenopausal women randomized to annual transvaginal ultrasound scan CA125 checks or just observation showed no clear benefit of screening. Women with a family history can be offered counseling and testing for genetic mutations in BRCA1 and BRCA2 genes. Those with the mutations are offered prophylactic salpingo-oophorectomy. Clinical features. History. Symptoms are often initially vague and or absent, and 70% of patients present with stage 3 to 4 disease. Increased awareness amongst women and GPs of warning symptoms and signs is vital to achieve earlier diagnosis. For example, persistent abdominal distension, bloating, feeling full, early satiety, and or loss of appetite, pelvic abdominal pain, or increased urinary urgency and or frequency. Many of the symptoms are similar to those of irritable bowel syndrome, but since this rarely presents for the first time in older women, ovarian cancer must be excluded. It is important to ask about breast and gastrointestinal symptoms because a mass may be metastatic from these sites. Examination. Examination may reveal cachexia, an abdominal or pelvic mass, and ascites. Very large masses are less likely to be malignant. The breast should be palpated. Is the ovarian mass malignant? More likely if rapid growth more than 5 cm, ascites, advanced age, bilateral masses, solid or septate nature on ultrasound scan, increased vascularity. Spread and staging. Ovarian adenocarcinoma spreads directly within the pelvis and abdomen called translymphic spread. Lymphatic and more rarely blood-borne spread also occur. Staging is surgical and histological. Investigations. Initial detection in primary care. CA125 levels should be measured in women over 50 with many abdominal symptoms. These symptoms include persistent or frequent abdominal pain or distension, bloating, loss of appetite, weight loss, and fatigue, change in bowel habit, urinary frequency and or urgency, or if symptoms similar to IBS. If the CA125 level is raised more than 35 international units per milliliter, an ultrasound of the abdomen and pelvis is arranged. If ultrasound or physical examination identifies ascites and or a pelvic abdominal mass, urgent referral to secondary care is undertaken. Establishing the diagnosis, secondary care. If not already performed, the CA125 is measured and an ultrasound is arranged. In women under 40, levels of alpha fetoprotein and HCG are measured to identify women who may not have epithelial ovarian cancer, levels being raised in germ cell tumors. The risk of malignancy index is calculated from the product of the ultrasound scan score, U, menopausal symptoms, M, menopausal status, M, and serum CA125 level. Our risk of malignancy index equals to U times M times CA125. The ultrasound result is scored 1 point for each of the following characteristics: multilocular cysts, solid areas, metastasis, ascites, bilateral lesions. U equals to 0 for ultrasound score of 0 points, U equals to 1 for an ultrasound score of 1 point, and U equals to 3 for an ultrasound score of 2 to 5 points. Menopausal status is scored as 1 premenopausal and 3 is postmenopausal. All women with a RMI more than 200 are referred to a specialist multidisciplinary team. A computed CT scan of the pelvis and abdomen and thorax, if clinically indicated, is performed to establish the extent of disease, but further staging is usually performed using surgery. Management of ovarian cancer. Assessment of fitness for surgery may be extensive as many affected women are elderly. Blood is cross-matched before surgery. Surgical. A midline laparotomy allows thorough assessment of the abdomen and pelvis. A total hysterectomy, bilateral salpingo-oophorectomy, and partial omentectomy is performed with biopsies of any peritoneal deposits, random biopsies of the peritoneum, and retroperitoneal lymph node assessment. In women with suspected stage 1 ovarian cancer, disease confined to the ovaries, the retroperitoneal lymph nodes are sampled. In stage 2 or greater, they are removed through block dissection if enlarged. For advanced tumors, the prognosis relates to the effectiveness of the initial debulking procedure. Patients who have complete debulking have a better prognosis. So-called ultraradical surgery is increasingly being performed, which may include bowel resection, splenectomy, and peritoneal stripping to achieve complete cytoreduction. In young women wishing to preserve fertility where disease appears early or is borderline, the uterus and unaffected ovary may be preserved, but meticulous further staging and follow-up are required. Chemotherapy. A confirmed tissue diagnosis is required before offering chemotherapy. If surgery has not been performed, then tissue for histology can be obtained through percutaneous image-guided biopsy or laparoscopy. If tissue or for histology cannot be gained, then cytology from parasynthesis of ascites can be performed. CA125 levels, if initially elevated, can be used to monitor the response to chemotherapy. Very early low-grade histology stage 1A and 1B chemotherapy is not usually given. Other stage 1 high-grade stage 1C 6 cycles of the platinum agent carboplatin are used. Stage 2 to 4 carboplatin or cisplatin alone or in combination with paclitaxel is used. Two-thirds of women whose tumors initially respond to first-line chemotherapy relapse within 2 years of completing treatment. Many women now receive neoadjuvant chemotherapy. They do not have surgery initially but receive chemotherapy and have surgery halfway through the course of chemotherapy. This causes less morbidity, although current evidence suggests there is no difference in survival with this approach. Early stage malignant germ cell tumors can often be adequately treated with removal of the agnesa alone, allowing preservation of fertility. Higher risk and more advanced germ cell tumors are usually treated with chemotherapy and are generally highly sensitive. Whilst these germinomas are sensitive to radiotherapy, chemotherapy is more effective and so preferred. Follow up and prognosis. Levels of CA125 are useful after as well as during chemotherapy. CT scanning aids the detection of residual disease or relapse. Interval debulking of residual tissue, if not all could be removed at first surgery, may be beneficial, but routine second look laparoscopy and laparotomy to monitor the response is not. Chemotherapy prolongs short term survival and improves quality of life. Poor prognostic indicators are advanced stage, poorly differentiated tumors, clear cell tumors, and slow or poor response to chemotherapy. Death is common from bowel obstruction or perforation. The prognosis of ovarian cancer is improving, but largely for the minority of women with early stage disease. Support. Women must be offered support and written information, including regarding psychosocial and psychosexual issues and genetic aspects, throughout the process of investigation, diagnosis, and treatment. This should be appropriate to them and their disease stage. Palliative care. Only 30% of women are cured of their gynecological cancer. Ovarian cancer causes the most deaths, but the principles outlined are applicable to all terminal disease. Definition and aims. Palliative care is the active total care of the patient whose disease is incurable. The aim is to increase quality of life for the patient and her family. This involves addressing symptoms such as pain, nausea, bleeding, and symptoms of intestinal obstruction, as well as meeting the patient's social, psychological, and spiritual needs. Care, therefore, needs to be individualized. Important issues include the problems of prolongation of poor quality life, euthanasia, symptom control versus drug side effects, making the transition from curative to palliative care, and resource allocation. Organization of palliative care. Three levels of care are involved, usually working together. The general practitioner, specialist practitioners such as Macmillan nurses, and specialist hospices or gynecological units. Symptom control, pain. The analgesic ladder describes the differing analgesic strengths of drugs. Co-analgesics such as antidepressants, steroids, and cytotoxics may also be used. Accurate appreciation of pain and drug side effects is important. Opioid analgesia can be patient controlled and is normally accompanied by antiemetics. Alternative therapies such as acupuncture or behavioral techniques may allow greater patient control. Nausea and vomiting affect 60% of patients with advanced carcinoma. It may be due to opioids, metabolic causes, for example, uremia, vagal stimulation, for example, bowel distension, or psychological factors, all of which should be addressed. Antiemetics include anticholinergics, antihistamines, dopamine antagonists, or 5-HT3 antagonists, for example, or ondansetron. Heavy vaginal bleeding may occur with advanced cervical and endometrial carcinomas. High-dose progestogens may be helpful. Radiotherapy is often used if it has not been used before. Ascites and bowel obstruction are particular features of advanced ovarian carcinoma. Ascites is best drained slowly by repeated paracentesis. Obstruction is ideally managed at home. Spontaneous resolution occurs in up to one-third of patients. If obstruction is partial, metoclopramide is used, pro-motility and antiemetic, and stool softeners with enemas for constipation, and a trial of dexamethasone to reduce tissue edema. For complete obstruction, cyclizine and ondansetron are used for nausea and vomiting, with hyoscine for spasm. The patient is encouraged to eat and drink small amounts as she feels able. Some may be managed for many months like this. Surgical palliation is indicated with acute single-site obstruction. Stents may also be inserted low in the sigmoid colon or rectum. Terminal distress. The last 24 hours are often the memories that the relatives will retain. The terminal stage should be managed sensitively with time for the patient and relatives in a quiet environment. Good symptom control and with anxiolytics and analgesics without overly sedating can allow valuable time with the family. Classification of ovarian tumors at a glance. Tumor-like conditions include endometriotic cysts, follicular and lutein cysts. Primary tumors include benign, borderline, and malignant types. Epithelial tumors include serous cystadenoma, benign or malignant, mucinous cystadenoma, benign or malignant, endometrioid carcinoma, malignant, clear cell carcinoma, malignant, Brenner tumors, benign. Germ cell tumors include dermoid cyst, benign, solid teratoma, malignant, dish germinoma, malignant. Sex cord tumors, granulosa cell tumors, benign or malignant, thecomas, usually benign, fibromas, benign. Secondary malignancies, usually from breast or bowel. Carcinoma of the ovary at a glance. Epidemiology. Causes most gynecological cancer deaths. Postmenopausal, more common in the West. Pathology. Epithelial 90%. Germ cell tumor if less than 30 years. Etiology, family history, nulliparity, early menarche, late menopause. Clinical features, silent in early stage. 75% present in stages 3 to 4, usually with abdominal bloating, distension or mass, pain or vaginal bleeding. Screening, not routine and limited use. Ultrasound scan, CA125, and family history or gene testing. Investigations, ultrasound scan, CA125, risk of malignancy index, CT, and surgery. Staging. Stage 1, ovaries only. 1C with capsule breach or malignant cells in abdomen. Stage 2, pelvis only. Stage 3, abdomen and pelvis. Stage 4, distant including liver. Treatment. Surgery, total abdominal hysterectomy, TAH, bilateral salpingo-oophorectomy, BSO, omentectomy as staging laparotomy, lymph node biopsy or removal, debulk all advanced tumors. Possible laparoscopy and oophorectomy alone for young women wanting fertility. Very close monitoring. Then chemotherapy unless borderline or low risk stage 1A or B. Prognosis poor, less than 50%, 5-year survival because of late presentation. And that's the end of the chapter.